Welcome, everyone. Welcome. I'm going to pass this around if you have a category person who needs this. I think I know many of you, but not all of you. My name is Chris Colvin. I'm the head of Division of Social and Behavioral Sciences in the school. And I'm going to be presenting on mostly other people's work, but on a project, work that's coming out of a project that I and others are overseeing in the division, our kind of main big research project. I'm going to pass, I've got 20 copies of this. If you've already seen it before, pass it along, please. So what I'm going to do, I'm going to give you an overview of some of the key findings that have come out of the qualitative research that we've done on the topic of men and HIV, men, masculinity, and HIV, in the place where we've been working, which is Gugulethu, essentially, Fontaine subdistrict, Gugulethu, as part of a project we call iALARM. iALARM stands for Using Information to Align Services and Link and Retain Men in HIV Care. It's on the handout that's going around. And the iALARM project is a 5-year, it's a R01 funded project that has two main components. The first component is a health systems intervention, health information systems intervention. So we are trying, which I'm not going to talk about. That's the kind of other half of the project. So we're trying to use new kinds of access to new kinds of information that we have on our side and bring that to the table and bring other people together who aren't normally together, and see what happens. And that's the kind of health information systems intervention part. The part I'm going to be talking about is that intervention is a health information intervention, but it's focused on the problem of men and HIV. Right, so that's the kind of topical thematic focus. And so, in addition to this information piece of it, we're doing also qualitative research on men, masculinity, and HIV in the setting. And so, what I'm going to be doing is taking you through some of the key findings from that work. It's a bit of a maybe unusual format for new meetings. I'm going to give you a quick rapid-fire overview of 10 of the projects, or 10 of the papers. There's more projects than this, but kind of 10 of the theses and papers that have come out of it. What you have in the handout is kind of half page for each project. Right? So you've got the kind of official title, the name, what institution they're from. This is a collaboration with Brown University. So about half the students are ours, and the other half are Brown University students, and Michigan, and a couple other places. So I'm going to do is I'm going to present first some overarching findings that were common, kind of emerged across a number of studies. I'll talk to you about those. I'll take you quickly through the kind of some of the highlights of the individual studies, and then talk about some new research directions kind of coming out of this work and what a kind of next phase of the qualitative work is going to be. So first, I'll take you through some of the kind of overarching things that are coming out of the project. The first one, HIV stigma is real and persisting in Gugulethu. On one hand, this seems like not a surprising finding. None of us were surprised in the abstract to hear that stigma was still a problem. But I think there are 3 reasons that we wanted to kind of highlight this finding kind of front and center. One was that there's a sense, but I don't know, actually, I personally don't know how much research has been done or kind of how people think about this, but stigma was really bad in the beginning of the kind of critical period of the epidemic when the most people were dying, when the least access to treatment was there, when it was most terrifying in a way. And stigma was really high. because of access, because of treatment, because of time, because of all kinds of things, I think stigma has maybe lessened, it might have changed, it might have transformed, but certainly people talk about stigma being better. You hear that from people, that it's not as bad as it used to be, or it's different than it used to be, or and one of the things that came out in the interviews was that this is still really a kind of an active, and it's a real problem still. Whether it's changed or not, whether it's reduced in scale or not, it's still a real problem. Right? So that's the first reason. Second, I think the second reason we headlined this is that the handout that we gave is, and these slides actually, are the summary versions of the findings that we've been using to feed back to the people we've been working with in Gugulethu. So the health systems, staff and managers, the NGO, staff and community activists and kind of regular community members. And they also seem to respond, this kind of resonated with them when we talked about stigma, and that it feels like people don't talk about stigma much anymore, but it still is really important. So we've headlined it for that reason. And the third reason is that I've spent much of my time in working in Kaivicha. And I think doing this project in Gugulethu has made me aware of the quite stark differences in mobilization, awareness, consciousness around HIV. And there's a sense in Gugulethu that they've been passed by, that they are years behind in terms of kind of being aware and mobilized and kind of effectively kind of engaged. And so this also speaks to the idea that Gugulethu is a different space than Kaivicha. And people feel that, they think about it, they talk about it. Second point, just that men face a wide range of barriers when it comes to avoiding HIV and getting the care that they need if infected. This is also probably a less surprising finding in a way, but we also found that when we talked about this and brought this up in conversation with the kind of test team that we run there, there was still a lot of interest. This is still a kind of fresh issue for people, these problems, and they feel like there's not enough talk about it, and they want to know more and talk more about these issues. They see them, they experience them, but they want to talk more about them. We tried, though, to focus a lot of the work on trying to say, well, we know from the literature and from our experience that there are these barriers, but what else can we do beyond that, right? What other aspects of the problem can we understand? And a number of the projects you'll see in there focus on men who are successfully kind of stable and adherent on ART, ones who have managed to spend a number of years, and we've asked the question about what is it that makes them different, if they are different, or what are the things that have enabled them to successfully stay on ART, to be resilient, if you use that framework, to understand what worked for them. And we identified a range of both individual and interpersonal and kind of family-related factors, but also the kind of importance of community mobilizing, whether it's for HIV or not, or gender or not, but the kind of the impact of being part of NGO work, of volunteer work, of work that brings people into connection with each other and out of their houses and into a bigger space was often talked about as quite important. We have one project, we talk a lot with healthcare workers and managers in the project, but we had one project that specifically focused on their experiences of working with men in the system, to try to understand how, what that's been like for them. We have a lot of experience in the literature and in our own research about how men feel about the healthcare system. And they feel like they're not treated well, they don't want to see a female provider, they feel shamed, disrespected. They also don't want to go to the clinic. and so they're much sicker, and the clinic feels like a female space. So we know we have a fair bit of information about what men feel. Makes it difficult for them to access care, but there's actually much less research on how the people in the system itself experience this. And we heard a lot of frustration about wanting to help men, feeling like they were just out of reach, or when they came in, they got lost too easily, and not knowing really how to keep them engaged. And we heard some kind of creative strategies for trying to keep them linked. Men spoke about the importance of living a positive life in confronting HIV and the encouragement they got from building a life beyond HIV. This is just the idea that it's fine to talk about treatment and to be treatment literate and to kind of be up to speed on managing your health, but actually living effectively with HIV involves a much bigger imagination, right? It's about trying to rebuild a sense of who you are and what your future holds, and what's possible and not possible for you. And the final overarching point, men wanted more spaces in Gugulethu where they could come together and speak about HIV and other challenges they were facing. One of the things that came out in a number of the studies was the sense of isolation I think many men feel, both in their families and in their peer groups. It's not that they didn't have families, didn't have social connections, didn't have lots of friends, but the isolation came from not feeling like they could talk about things that were important to them, things that they were worried about that made them vulnerable, health problems, relationship problems. And there are a range of reasons for why they felt like they couldn't do it. But in general, there was quite a strong theme of really not having spaces or opportunities, or even knowing how to have kind of some of those conversations. It not being kind of part of a habit, or part of the kind of local culture. And in some of the work we've done with Somke and movements for change in social justice, which is another kind of social movement in the area, and others, when those spaces get created for men to start to talk about what it might mean to be sick and not be sure, or to be infected but not be sure if you are, or to be sick and not know how to access care, they really responded. You could see that it was meeting a need, meeting a kind of a lack. So we didn't sit down and have interview questions where we said, do you want more safe spaces? And they didn't tell us we want more safe spaces. But when those spaces emerged, you could see that they responded to it. And of course, the they is the ones who come to the group, right? So I can't be talking about all men in Gugulethu, but there's certainly, it's not only the people who are part of the small inner circle, right? These are events with 100, 200, 300 people, kind of, invited ad hoc, kind of fashion, and it has been, quite a response that's important to learn from, right? Because it tells you something about that experience. So what I'm going to do now is give you the quick roadshow for the other projects. I'm not going to get into talking about the research question and the methods, because it'll be too much for you to digest, but I just want to give you some of the highlights and show you some of the individual things that our group had been working on. These are all student projects. Yeah, all student projects, all either in PhD theses or PhD, either from UCT or from Brown or Michigan. And there are other projects besides these, but these are the ones that are the kind of gender qualitative research on gender HIV. So Rutendo is an PhD student of ours who is the one who spoke with the healthcare workers. And I've kind of underlined some of the kind of distinguishing or important findings from each one. Certainly the nurses she spoke with said that denial, again, was still very common. It was usually the first initial response. The most important things to help people stay in care were to not be in denial about their status, but especially to have someone supportive to disclose to and help them manage their stigma. So this was, again, also another theme across, that's having, even if it's just one person, if you haven't told anybody else, having that one person is a vital link. And they had some nice examples of icebreakers and jokes and other ways of trying to make men feel more comfortable. One thing she found was that some, maybe sometimes it was the same nurse, but sometimes they had to become more formal and more professional and more kind of, this is just a clinical encounter and I know what I'm doing, and the men could respond to that. And other times, or other men maybe, responded to becoming less formal, right? And kind of naming the awkwardness, or trying to kind of break the ice. This is very small. Sten Viso was another UCT master's, looked at men in HIV testing. Generally, there's quite good knowledge about testing in the area, about generally where you can test and how testing works. A lot of men said they felt fear of being stereotyped by clinic staff when diagnosed with HIV, or even when being tested. Coming in and just asking for an HIV test and being stigmatized because they are seen as the problem, right? And not wanting to kind of go through that. And a very similar set of facilitators, family, friends, good HCT counseling, and also having a kind of plan in place for yourself if you're positive. So being able to think through, do I know what my next step is if I'm positive? And a general interest in a positive lifestyle. Julie Calloway's a master's student from Brown, and her conceptual framework was resilience, and she was trying to understand men who had been on treatment for a number of years, and on paper didn't look that different from the other men in the area, right? So these were not richer or better educated, or the gender activist who works for Sonke. It was just kind of ordinary men. And again, kind of the kind of common ideas about accepting your status and having people in your family who could support you. A lot of men got support from their wives and partners and from families. Again, here and in several other projects, there was a sense that maybe your partner, maybe someone in your family. We heard much less about men talking about friends who were their point of support. Like if you had one person you disclosed to, it usually wasn't a friend. It was a partner or a mother or a child or someone else. Jenny Duda is a master's student at Brown, and her project took a more kind of process-oriented approach, trying to think, how do you move from not thinking about getting tested to getting tested to getting diagnosed to working through your reaction to that, getting on the treatment, and trying to identify for the men who, successfully made that journey, what were the key milestones. Support, again, motivation, obviously the strength that you feel after you start on treatment, and feeling like they had become freed in a way, and once they'd accepted their HIV status, being now freed of HIV and able to think about their life in a bigger, broader sense. One thing I want to just pause here and say is that a lot of these, when these projects first started, coming together, and we're starting to look at what people were saying, in some ways, a lot of it, it's very familiar to me, both from just the masculinity and HIV research, but from the general HIV research, right? General kind of experiences of HIV research. What I've noticed in, however, feeding back and being part of this ongoing task team and kind of bringing this research information back to a group of NGO staff, community members, healthcare workers, is that they don't have they know all this kind of intuitively. They see it and experience it, but they also don't have the luxury of kind of sitting down and thinking about it and reading about it all the time. And having this information kind of fed back to them, it wasn't that it told them something they didn't know, but it allowed them to have a kind of a conversation and just start thinking through things in ways that they hadn't before, right? So, and to help give them ideas about how they can take what they're currently doing and try to shift it in relation to these findings. So it's been nice to see that. This was quite an outlier project in some ways. I had a student who came, wanted to work in Hanover Park on HIV, masculinity, perceptions of risk, and in particular on gangsterism and how the kind of presence of gangs and the kind of concept of gangsterism shaped sexuality, sexual practice, HIV risk, and health practices. And so what she's been working on is, this is included because Hanover Park is in kind of broader sub-districts that we originally had framed the project. And we found also that it's been a really useful point of comparison. So it's very easy, like me working in Gugulethu, it's very easy to kind of think that that's the world, and then you go to Gugulethu and you realize there's differences. And you go, across Danafontaine, right? You go across Danafontaine, and you get to Manenberg or Hanover Park, and it's, again, an entirely different world. And so those points of comparison are really instructive. And I think we were working on a paper trying to compare. I mean, there are obvious reasons why Hanover Park and Gugulethu look and feel different. And it's obviously historical and contemporary reasons, but we're trying to think more deeply about how that then translates into these more specific concerns around masculinity and HIV. So she's done a kind of ethnographic project on what it means to be in a gang, what the positive, in terms of how gang members perceive it, what the positive social value of the gang is, as well as the negative. The walking politics, that some clinics are in areas where people can't go, and vice versa. And one of the really interesting things that she completely buried at the end of the first art, she's working on her first kind of proper article. And at the very end, at the discussion, she brought up this idea that actually gangs are much less clear and stable an object than we imagine, than even people imagine. They talk about there's the gang. You are in it or you're out of it. And that's gang territory and that gang territory. It's very, people talk about it as if it's very clear rules, very clear organizational routes. They'll turn around and say, I don't know if that street is this or that, right? Or I'm not in the gang anymore, but I did this thing for them, but or sort of in and out. And when you look more carefully, the gang as an idea is kind of different from what the gang actually is in practice. And that's a useful kind of just object lesson for any kind of social phenomenon, right? Where we have ideas about what a man is, or what the health system is, what a gang is. So I'm trying to get her to highlight that more. Katie's Brown and master's student looks more specifically at social support. So that took that specific lens, kind of coming out of more of psychology, and tried to think about what are there's different models for different types of social support, and trying to think about what are because we throw around social support like we know what it means, and it's always a good thing. And so her project tried to look more closely at this. Found that there were two kinds of support: instrumental support, especially money, and appraisal support, which is kind of being helped to appraise what your situation is, being helped to think about it, were the two most kind of valued forms. And I think that speaks also to the kind of desire for spaces where you can talk about what's going on and the lack of opportunity to do that. Henry did some work with community mobilizers. So Sonke is a big presence in Gugulethu. They have a men's wellness center there, and they're one of our partners in the project. And as part of their work, they have people who are part of a community action team, and they're people who are called community mobilizers, who do the kind of outreach and awareness raising work. What started, kind of what sparked the interest in the community mobilizers experience was actually my having observed over the years the ways that Sonke, gender justice, I assume most of you have heard of Sonke, kind of one of the biggest, if not biggest, kind of gender-related NGO in the country. The ways in which they struggled to handle it when staff members said things that didn't toe the party line, the party gender line, right? So people would say things that were seen to be or were misogynist or sexist or otherwise problematic. Within Sonke, and I've talked with a lot of people, and they kind of admit that this is part of the dynamic. They don't talk about it. They shut it down, and then you learn quickly that you're not allowed to say that, right? Which is probably the politically correct and strategic move as an organization, perhaps, but it always felt a bit short-sighted to me because those things don't go away just because you shut them down. And if these are your community mobilizers, your gender activists are saying things that you find troubling, then you have to think about that. Like, you know, and it's not that you hired the wrong people and you have to go find other people, right? The world is full of people who don't agree with your one perspective. And especially if you're going to try to sit and do long-term engaged community work, where you're trying to meet people where they are, in the kind of cliche, and to try to figure out how to sit with them and move their thinking and their practice to a different place, you have to be able to deal with this kind of ambiguity, the kind of conflict and contradiction. So Henry's project was a kind of first step in trying to understand what is the experience of these community mobilizers like. When do they come across these tensions, you know, between what Sonke wants them to say but what they actually feel, and kind of what happens when in those points of intersection where they can actually kind of meet people and start to talk. Sam is a master's student at UCT, and she, in a similar kind of way, worked with men who were part of a social movement that grew out of the kind of work that we in Sonke have been doing. It's the movement for change and social justice. And her project kind of begins with the idea that a lot of volunteer community development work is that kind of work is typically gendered, right? It's typically women who do it because it's development work, it's volunteer work, it's altruistic, it's not a proper job, right? And there were a number of men who were involved in leadership and not leadership positions in MCSJ. And she was kind of looking at how they experience their involvement and whether they perceive that to be going against a kind of masculine norm or not. I think we were talking yesterday about how in some ways the families push back, right? They're like, this is great. These are real problems, and we're happy for you to be working with our community. As long as you can do that and have a proper job, right? You're still not bringing in money. This kind of organizational work is not a real job. It's not a proper thing. So they did face, certainly from their families, a fair bit of resistance. They really felt, though, like being involved in the movement gave them a way to more to address some of the dilemmas they were facing in kind of performing and achieving the kind of masculine role that they wanted, right? So generally speaking, they weren't working, they hadn't had much education, they weren't providing for their families, so their identity as kind of effective, strong men had been under threat, right? And being involved in this movement in the group was a way to try to reclaim some kind of positive masculinity. We got two more. Okay. Myrna's got another bigger, different project for her PhD, but she's been also writing a couple pieces also on the gender piece more particularly. And this is a piece that looks at challenging harmful stereotypes of men. And I started off saying early on about how men often felt like they didn't want to get HIV tested because they would be seen as they know that they're seen as the problem, right? As they're kind of pathologized, right, in a lot of their interactions, both with the health system, but also with family members in general. This is a harder thing to get men to talk about or to kind of have it be part of an explicit conversation, but you read it, in the ways that they talk about their experiences. And so this is part of what Myrna's been trying to also lift out and think more about. And the final one is a piece that Myrna, Eleanor, and Bea have been working on, who are all been involved in the project in different ways, but are all women who've been working on a men's health project that's been trying to working with men and women, but on the issue of men's health. And also doing a lot of work in that ambiguous space that I was telling you about, right? About that the community mobilizers are in, right? Where it's not all kind of perfectly correct discourse, right? That's kind of emerging in meetings. And they, in this paper, reflect on a particular event where there was language. It wasn't dramatically offensive, but there was language that was uncomfortable, like a metaphor, and that felt wrong and awkward, and people kind of laughed about it, and it wasn't really kind of talked about, and so they are reflecting about how that made them feel and what they could and couldn't say, what they felt they couldn't say in different spaces as well, because there's the test team, there's our own project team, there's a broader community, there's different contexts they're working in as well. So this is kind of a reflective and methods piece in a way about being a woman working on a men and HIV project that is dealing with gender transformation, but in this kind of complicated kind of context. And the last bit here, which is not on your handout, most, I'll take you quickly through it. Just some of the new research directions we're thinking about. I'm particularly interested in trying to do more on the experience of male community mobilizers and gender activists. I think this fact that people don't arrive in the world fully formed as kind of enlightened, ideologically pure beings, is my beginning point. Like the fact that we don't arrive like that is my starting point. And then what's interesting is how that complicates things, from that point on, right? And if your work is to do gender transformation work, you have to wrestle with that complexity. I'm interested in particular because I come from an anthropological point of view where I have a complicated relationship to activism, because all of my training in anthropology was about, you think you know it's right, but this is why you do anthropology, because you don't, right? You think you know how the world works, and you think your values are the right ones, but look over there. The world looks different over there, right? That's the basic move of anthropology, right? You don't have to become a complete cultural relativist and kind of give up on everything to do that. I support the values and the politics of Sankei, but I'm also an anthropologist, so I can't just go out and tell people that they're wrong. Like, you know, and the men who are these community mobilizers also, they're in a different position. They've been told, and they want to go tell men that they need to change, that, you know, something needs to change about this situation. But they also don't quite also always agree, you know, with what they're supposed to be doing. So to me, that's a really interesting and important thing to think about, right? Because it's more what real life looks like. That's where the kind of hardest puzzles to solve are. We're interested in trying to do more work on processes and theories of gender transformation. And these are a bunch of just fancy terms about things that might matter in that process. So we talk about gender transformation. Sankei talks about gender transformation. We talk about it in general. And Sankei, especially over time, has developed quite a kind of rich, multi-layered approach to this, right? So it's not, they're known for kind of doing workshops and campaigns and whatever else, but they also do policy work, and they do increasingly a lot of legal work. So they're trying to tackle the problem at a lot of different levels, right? But kind of in the context of Gugulethu, what we see is the workshops, right? And the kind of door-to-door and the kind of awareness-raising campaigns. And it always feels, not insufficient isn't the right word, but it always feels like the time horizon is too short, right? Because if we believe that gender is both socially constructed and therefore mutable, but also one of the most fundamental facts of social life, right? It's a fundamental organizing principle. It permeates everything. Something like that should be, by definition, really hard to change, right? It's not something that it's just a matter of changing or educating or raising awareness. That may produce some initial movement, but if gender is a thing that structures everything all the time, how would you change that? And it changes, so we know that it's not static, it's always changing, and we can push it in certain directions, but how that actually changes at a deeper level and how our theories of how that changes connects back up to the day-to-day work that Sankei or we or others are doing, I think is an important kind of thing. I think there's very little theory about this. There's a lot of description of what is good and bad about the status quo and what, you know, problems there are, but not, and the need for change, but not much theories. And I think thinking about how practice theory and social theory might be an additional way to think about how change happens is useful. The community mobilizing work, and these other things about social political imaginaries, intersectoral and intersectional dynamics, femininities. All of this is about how to broaden the perspective, because too often the question is, how can men change, right? Of course, if we think back to basics, men are by definition always in a field of, as individual beings, they're in all these other sets of relationships and contexts, and they can't change without those other things changing, right? So how do we think about the changes in masculinities in relationship to changes in femininities, or changes in class identity and class formation, whatever the kind of things are. So you can't think about this one thing unless you're already always thinking about these other things as well. We have a new grant to do some more, in some ways, straight ahead work on evaluating models for mobilizing men. So this is kind of case studies on what are more or less effective ways to try to, well, whatever we mean by mobilizing. But in the context in kind of Gugulethu, it's about trying to raise awareness, increase testing, improve linkage and engagement. And finally, among the 30 other things I'd love to do. There's been these men's dialogues and men's forums that MCSJ has been holding, which are these, like I said, these groups that we didn't plan, but like all of a sudden, all these men are coming and they're having conversations they said they haven't had before, and there's lots of debates and whatever else. And they're filming them all. We didn't do it. And they know, everyone knows they're being filmed. It's all been agreed on. The kind of leadership in the group. They want to document this for two reasons. One, to kind of use for promotional, right? The movement is filming it for kind of promotional reasons and to get things out there. And they also realize that having little clips and showing them to people are really good ways of generating discussion, right? So they want to also film things so they can have these little clips to generate discussion. So I would love, and it's all in Xhosa, right? So it's with some switching in and out of English, but it's not translated into English kind of thing. So I'd love to do a project that really looks at in a kind of close linguistic and discursive analysis way, like what are the words people use, how do conversations unfold, what are things not being said, how are things translated, and we've got this kind of accidental, body, which it's an archive. Which would be nice to be able to do something with. So yeah, so that's where we are hopefully heading with some possible directions. Stop there and take some questions.
I have two questions related to stigma, I think. Whether comorbidity with TB influences some of the earlier projects, dynamics and resistance and treatment and accessing diagnosis, and also whether same-sex male-male sexual interaction as a role in the HIV infection has some of the, if that's part of the stigma as well, in terms of how men feel like so it's not just about the HIV, it's about whether they're going to be perceived or related to any possible gay relationship. Okay. So I don't know.
Okay. My sense is that the TB-HIV interaction is quite important. I mean, both biologically, but also epidemiologically, but also socially, right? So the TB rates, and
yeah, it's related to whether it comes out in the research, whether it emerges as that's right.
Men didn't talk about TB, but we also didn't ask them, right? Which is the dilemma of a lot of qualitative work. And we didn't hear anything. There wasn't anything that I can remember that related to the coding of HIV is related to men who have sex with men, right? I don't think that's. I can't think of anything in the transcripts, and I don't also kind of experience that.
I just wondered if it came out in their conversations in terms of some of their barriers, or stigma. Yeah,
others may have different experience, but I haven't perceived that to be a link that people make. So, slightly separate point, but there's who is it doing this? The Stellenbosch group we were with. There's a new project that a PhD student at Stellenbosch that we're working with has been involved in, and it's looking at how, because HIV in the kind of heterosexual population, well, for the whole population, because of the nation's characters in the country, largely heterosexual population has become normalized, routinized to some degree. There seems to be kind of a paradoxical re-stigmatizing of key populations now is emerging back as a new category. It was a category 20 years ago, and now it's a new category, and it's coming with new kinds of stigma as well, right? Because HIV is seen to be declining and managed and treatable, and if there is problems with HIV, it must be because of young girls or because of MSM or drug users or sex workers, or but
I just wanted to find out the profile of the men that you were talking to. In particular, I was interested to see if there's a difference in age. Do the younger men feel differently to the older men? And was there any difference, or are you able to comment on that?
Mm-hmm. It came out, certainly the generational differences are really important in interactions, right? And you know, who the community mobilizer is, or, you know, it really matters whether they're 25 or 35. Sam, do you want to put you on the spot? Do you want to talk about some of the generational stuff that came up in your, about the kind of the 25-year-old is in a very different place in its life than the 35 and have different expectations.
Yeah. So in my research, the younger men, expectations for the younger men were what I define as younger men were over 18, but not old enough that they were in positions of being breadwinners. And the older men in my study were people who were supposed to be breadwinners but didn't have formal employment, and so expectations of the younger men were that they were supposed to be either looking for a job or going to tertiary, like trying to access tertiary education. And if they weren't doing that or actively doing something, for them, the escape was then volunteering, so that they could show that they're not being lazy and that they're actively seeking employment through volunteer work that should lead them to getting a job. Versus the older men who it was really tough for them to be doing the volunteer work, because for them they were motivated to do the volunteer work for purposes of improving their community, and they actually felt strongly about doing the volunteer work that they were doing, but their families were frustrated with them for not taking on formal employment and almost prioritizing their community and their communal family as opposed to their immediate family. So I found that very interesting.
So they were both meant to be independent, but the older ones had bigger pressures.
Yeah.
The two other kind of thoughts I have is, one is that most of the men we're working with are either people that we found kind of through the public services, through Sonke's work, men who aren't working during the week, right? So there's a real class, we end up focusing on a particular class within Gugulethu, and there are a lot of people who use private medicine or who are kind of upwardly middle class, kind of living Gugulethu. So that's one just thing to know about what we're looking at. And the other thing, which has to do with generation as well, and it's a new thing that we're just finding out about, is, I don't know if you've heard about this idea of the kind of the three generations in Gugulethu and the kind of crisis of the three generations. Mm-hmm. The Gugulethu was set up, I don't know exactly when, but it must have been in the 70s, 60s, 80s? 40s. Lango was in the 40s, right? Yeah. And Gugulethu came.
That was before the 40s.
Okay.
It was the original township.
Yeah.
From like 1910.
Okay.
Yeah.
So there's a period where Gugulethu was created and settled, right? And there's a kind of generation that came into that period. And what people are talking to us now about are these real crises within households, where they frame it as the problem of the three generations, that you have people who are now grandparents and who are living in the house that they grew up in, right? And then there's the middle generation who should have grown up and moved, but they haven't because they can't. And now the third generation is becoming adults, and they need the middle generation to get out because they also don't. And so there are these real fights over title to houses and land and all kinds of problems. It's not distinct to Gugulethu, but it's distinct to kind of a situation where you have a settlement that's created, right? And then you have a lack of opportunity. That means it's hard for people to get out or to broaden or to.
And it also puts pressures on men who's obligated to give money to taking care of the home.
Exactly.
Because the middle generation has a lot of pressures with older men. to take care of the older generation as well as the younger generation. But at the same time, the younger generation is almost obligated to start paying their dues, because if they're going to stay with them, you need to show that they're growing up, because they're no longer being viewed as children, because everyone needs to eat.
Yeah.
And with regards to stigma, was there any generational difference?
It's a good question. It didn't come up. Again, we didn't look for it, right? You know, specifically. I can't remember if there are any. Does anybody else remember any distinct patterns?
No.
I just happened to look at Myrna. It's not that she has the answer.
I don't really have the answer, but there are, well, I'm just thinking about Stephen Lisa's work or my supervisor. There were some ideas that differed between generations around stigma and access to treatment and HIV testing, as well as where to get information around HIV testing from social media to, informal networks, to go into a bar. Very often, taverns and shabeens are named as places where you can actually get information around testing. I think that is the biggest thing.
Yeah.
I remember from the difference in. But I think, in terms of stigma, I think both groups that we work with, younger men and the older men, both agree that there's stigmas and taboos that have to be addressed.
My point of contrast also is Kailicha, and I haven't seen this pattern in Gugulethu, but in Kailicha, what I've seen in some places is the older generation. This is not stigma that people face, but their own stigmatizing. That the older generation, or midlife, men are less stigmatizing than younger ones, and less and feel more able to resist stigma, the older men, because they came up in the early 2000s, and it's now 15, 20 years later, and there's not the mobilization there was in 2002. Right, so they were part of, particularly in Kailicha, in those particular years, they were exposed to things that 18-year-olds today aren't. Right, it's very invisible, and so I don't think in Gugulethu there was that change, but it still feels invisible, like it does in Kailicha, or much less visible. Colvin?
So I have 2 points and questions. So the one is just in relation to the idea of generational changes. It strikes me that there's quite a similarity between what you're describing and what's emerging post-2008 in kind of some European economies where children have to move back. And so even when a generation has moved out, the current economic crisis means that now you have to move back in. And what that's going to mean about reconfiguring generational expectations and dynamics. So that was just a comment. I haven't been to many of these things, so I'm not sure if this is the usual kind of configuration of participants, but it's quite interesting for me that an entire discussion on masculinity. So my question, rather translate outside of the external community space into the community of researchers?
I was just going to respond to that, Colin. Most of the people sitting here are either in the division or so that's part of the
I just did this.
There's definitely
meetings are predominantly women, regardless.
There's most of the, if I think about the broader field, most of the kind of prominent people who work in masculinity are men. But when I present or talk about my research or go to a meeting or whatever, and if somebody's going to come up and say they're really interested in the research, it's the woman.
And yet, just to build on that, I mean, those task teams has been really interesting because the composition of those task teams has changed enormously. And certainly the last one that we were at was almost entirely men. There were 4 male nurses there. It was really, really interesting. It had changed so much and an incredible engagement by those men in the, this whole thing of like everybody assumes men don't want to talk about health, men don't go for it, etc., etc. And yet, the moment a space is open for them, the response is absolutely unbelievable. So I think we have an incredible internalized prejudice about this that needs to be examined as well.
Yeah, and once you start opening it up,
when you start to open up, people just say, no one's ever asked me. It really is remarkable.
Absolutely. Yeah, and just a quick thought about your first point is that, yes, the changing household structure is immediately linked to kinship and gender, right? I mean, one of the easiest ways to emasculate a man is to say you still live with your mother, right? I mean, in a kind of popular cliche, but that shows that where your home is, it has a lot to do with what kind of gender.
Yeah, I was quite interested in that other paper that women were working on about being women working in men's health. So I'm curious about that.
Got two of them here.
Like the number of times focus groups or interviews with men in the Eastern Cape about circumcision, and it's just like, here I am. We've had these conversations, but that will be interesting. But I was going to say, a few years ago, I did a lot of formative research around men's attitudes on testing for the Brothers for Life campaign that grew into a big advert that came out of that. And I'm wondering, did any of these studies look at kind of how communication and the role of mass media or other communication messages on attitudes and shifting social norms? Is that something that anyone explored around treatment?
Yeah, the research projects didn't touch on that. It may have come up here and there, but it wasn't we looked at. But in the testing meetings, that's been actually quite a active conversation. So someone at one meeting said, when I go to the clinic, I look and it's not only women in the seats, but it's also on the walls. It's all women. I want to see pictures of me kind of there. And then that generated a whole discussion, and now there's a series of posters with not only with men on it and kind of health promotion, awareness raising things, but with men, like identifiable men from Gugulethu, right, on it. And this is the idea that they came up with, was to say it should be us who are on that poster, not just some generic male, but someone that they know they've seen walking down the street. So yeah, that's been a thing that people have really responded to and felt that kind of gap.
Yeah, and also actually this part of this presentation was presented during the testing and was actually asked, to get a summary of the work that you did, and then we first presented a summary, and then now it has to be appended because they want to actually go to talk about these results and actually spread them. Which is a complicated thing to do, to put it in a pamphlet. It has to be translated into Xhosa, so they can actually just go represent. And I think there's an idea of presenting part of this work to a group of men in Gugulethu in July as well. And it's like, no, we got people, like 200 to 300 men who really interested in doing this. So that spin-off of the hunger for communication and information has been, I think, a lot more than any of us expected in the team.
I think I realized I don't know if it's cynical or what, but I kind of assume everyone knows all this stuff already, and also people in Gugulethu already know all this stuff, right? Because I spent so much time, living here, but also studying and researching TAC and general and kind of health activism in general, AIDS activism, and being in spaces where people were getting tired of it, and I sit at the university and I'm awash in all this kind of knowledge, and I these kind of conversations have really shifted my understanding that actually people don't know, or it's not even that they do or don't know, but having the information is something different. Having something that you can do something with is different than having a sense of what the patterns are, or what your experience is, but you haven't talked to them about it. Myrna or Ellen, do you want to add to or revise my framing of your paper?
Okay, well, what you're saying about what everyone's saying about the composition of the room.
That's so notable.
But I think it is, like, it really is a big challenge because it's difficult to be, okay, well, it was difficult for me to be a woman who tries to be, like, empowered and aware of when gender norms are taking place that are undermining my value as a person and get angry about that in real time. But then you're sitting in a meeting and people are talking about, oh, you know, men, they really struggle to find time to come into the clinic and they don't like to wait for too long, so we're thinking about maybe a system where the men get to jump the queue. And then you talk to them, okay. And then, so, and you want to also, like, obviously the whole project is about men's need to have their challenges taken seriously and not to be considered as these strong and, you know, invulnerable entities who can overcome any challenge by themselves, to try to recognize the challenges and support them. But then sometimes we feel like that can only happen at the expense of
Yeah. I also found it really interesting what you said about the mobilizers and how their views seem to sometimes be so different than the company line. I think that's such an interesting issue that in all aspects of doing kind of health work, like, you know, whatever, even in my work with the women, I was, you know, expecting that my counselors have this certain kind of message, but practice so often people doing this field work feel so differently. It's quite a nice critical.
Of course, and it's the other way around as well. Exactly. Yeah. I mean, the intrinsic attitudes of a huge number of health workers, the immediate response of, oh, well, you know when men are like, all of this, it works both ways, you know. It's a difficult terrain.
Interesting critical analysis.
And the you know, the test team itself is also like this process, this space where this process is happening, and you need to protect that process, right? So you know, we've had only 8 or 9 or 10 meetings, right? I mean, it hasn't been going on forever. And say someone comes up with an idea like that and they put it on the table, then, you know, there's a calculation, you know, if you shut it down too much, they're not going to come back, right? So you want them to feel like, we value your input. I think there might be some problems that, you know, that we'll get there, and, you know, and there are moments where the tension is more sharp, right? Where people are making jokes about either women or about men, and you, like, normally you feel like you would want to say something, but you're not sure how to do that without just breaking the trust somehow or breaking the process. And then because it's a once a month meeting, it's easy to just kind of forget it, because you're not meeting every day. You can't kind of come back to it. That moment's gone, right? And then another moment happens another month later. It's not like you have a day-to-day thing where you can, you know, that gives me a chance to bring up this other thing. So, it's a complicated process.
I'm sorry.
Sorry, one more.
Let the man speak now. I was just thinking about something quickly. These important cases of stigma, these men that you spoke to, from their own experiences or what they heard from other people, was that distinction made?
Yeah, I mean, the way I think about stigma is not so much that it's a case or an event or an act, but it's a sense of the way the value system works. Who's, you know, who's valued and who's devalued. And if men pick it up from how people speak to each other, even if they're not speaking to them, they can read, and then some may have experiences of, to me then the discrimination is the action part, right, where you're being discriminated against because of stigma. So they may have had, some of them did have experiences of stigma, and some of them talked about being really shut out by family or by healthcare workers. But as much of it was this perceived stigma and internalized stigma, right? Where they just kind of, they know that it's out there. It's not that they've actually been direct victim of discrimination, but they see it. And so it conditions what they do. Thank you.